This is the big paper that came out many years ago now, saying heart failure is an equal opportunity player. It occurs about 1 in every 4 individuals, about 20. Now it's been updated. So Beacon Biosketch has just published in the Journal of Cardiac Failure, the lifetime prevalence of heart failure is now a little closer to 25% than it is 20%. So it's actually gone up a little bit, and we've known that. And that's still about twice, a little more than twice as prevalent as breast cancer in women. So keep that in mind. It is a big ticket item. Now, here's some good news. So we're going to go over each and every one of these trials in detail. No, we're not. It was a joke. This is what we're up against now. We see an increasing number of trials. It's hard to keep up. Bottom line is there have been large changes in standard of care for heart failure. And the most common therapy that's used in Canada today for people with heart failure, which is an ACE inhibitor and a beta blocker still, even as we speak. That is the single most common combination of drugs for people with heart failure and low EF. I know that they're supposed to be on all 4. You can see in the red line, that's the survival in this province, as well as mine, right now. Where we want to be is closer to the blue, which is if they're on all 4 pillars of therapy. And it has been clinical trials. This slide is based on modeling from clinical trials. It's not an actual real life study per se. However, these are the aspirations that we have. We want all of our patients to be on, if their EF is under 40%, we want all of these patients to be on one. This shows the 4 pillars, 4 foundational therapies for low ejection fraction heart failure. We've had new data with a new class of drugs, the SGLTs. Now there is actually a proven cardiovascular mortality benefit with these drugs at all ejection fractions. That's the first time it's been shown for patients with ejection fraction greater than 40%. And that led to, earlier in the year, this publication from the ACC indicating not 4 pillars, of course, 1 pillar, which is the SGLT for patients with ejection fraction greater than 40%. And as you can see on the line below, depending on particular patient characteristics, adding 1 or more other medications, many of which are the same, notably absent from this, beta blockers. And so the treatment of heart failure with ejection fraction under 40, intense, 4 drugs minimum, if you can, ejection fraction over 40%, 1 drug minimum, more if you can, depending on their status. A couple things that you may not have seen. I get this a lot, especially from general medicine and primary care practitioners. What about my patient? They're on a lot of drugs. They're very frail. They're very old. They have kidney disease. Well, some of these more recent studies have been planned to publish a lot of ancillary data in different populations. This one is from the SGLT trials and looks at patients who are on a lot of medications, and you can see that the results indicate a benefit irrespective of the number of baseline medications. So polypharmacy, well, don't stop that one. There's other reasons to stop medications. Maybe think of something else. What about in frail patients? We've known for many years that frail patients have worse outcomes. They do worse, but if they can tolerate the therapies that you take, that you give to them, if they can take them, they actually benefit quite significantly, even a larger benefit, absolute benefit, than people who have diabetes. So worth giving as long as they can tolerate medications. And then in high-risk populations, we have to remember that most of our clinical trials are in outpatients who have a relatively, and I say relatively, still a very high event rates compared to most prevention populations, but nevertheless, not nearly as high as the really high worsening heart failure or hospitalized population that you see on the right. And even in hospitalized populations now, we have data showing that improving the quality of care for patients with, in this case, low ejection fraction with an ARNI instead of an ACE inhibitor improves their outcome. This is our own real-world data taken from 13,000 patients in Alberta, and it shows that patients who receive evidence-based care will actually start showing a mortality benefit within 2 to 3 months. It's very, very rapid. So this doesn't take a year like some of the old statin trials. It doesn't take 1 or 2 years to demonstrate a benefit. This happens right away. So time is of the essence. So with all of these advances in good therapy, why do we need to rethink, and why do we need pathways to help us to do this? Well, first of all, it's self-evident. There's a lot of different therapies out there and a lot of decisions to make, and anything that we can do to simplify it will help. This just makes sense to us. But there's actually good data out there that we're not using the therapies properly. This is an alarming slide. This is data taken from US Census data, and it shows age-adjusted mortality rates from heart failure in young people. So in older people, I could show you this, it's rising. That's probably doesn't scare you quite as much. But this is people under the age of 55, and you can see that it's on the rise. There's a major problem coming. And so if it's happening at this early stage, where a small minority of the heart failure lives, you know what's going to happen later on. We've known for many years that in people who are followed as outpatients, that even though we want and try to advance therapies, usually not much happens. This is 1-year follow-up in a registry where they told the physicians, please treat your patients well, please advance their treatments. And you can see that based on a 1-year follow-up, almost nothing happens. And even in aggressive heart failure clinics, this is from the EPIC HF trial from Larry Allen's group, and they had some interventions to improve evidence-based therapies. I'm not going to show that to you. It did improve. However, what you're seeing here is there is such a high rate of non-treatment, i.e. non-change, non-improvement in therapies during each visit. 50% of visits, nothing was done. They actually created their own taxonomy to define the kinds of categories that you can put people in, clinicians and their patients, in for why the medication was not advanced, something wasn't started, wasn't increased, etc. And you can see that there's several of them where other priorities were higher, or just simple inertia, no reason, just we're not doing it and we're not telling you why. That's basically what inertia is. This actually extends to large outpatient registries. This is a series. This is from several countries of pooled registry data showing the same thing. Very little change. Time to median so-called optimization of therapies in these registries added together, approximately 9 to 12 months. So that's a long time. And if you remember those survival curves I showed you from Alberta, that means that more than 10% of these people are going to be dead before they ever get a chance to experience optimal therapy. It's a major problem. So what can we do to improve that? And so there's many different things. It's not just 4, but I've chosen 4 as kind of posterized to give you an example of things that can be done that have been shown to improve outcomes. And I put these 4 into these categories. So number 1, use the opportunities you get. Almost every patient with heart failure is admitted to a hospital at some point during the first 2 to 3 years of their heart failure diagnosis. Okay, still 50% of heart failure patients in Canada are diagnosed in hospital, okay, when they first are seen. So there's a huge opportunity. And they're a captive audience, and it's probably the safest place to do something to somebody because they're in a hospital and they're being monitored. And yet we've never ever taught that in the past. Use that as an opportunity. The second is keep it simple. Okay, I'm not going to say anybody's stupid because you're not. You're smart people, but you do have a lot going on. And even people who are highly experienced and expert in the treatment of heart failure, and I am definitely experienced, I may not be expert, I forget things all the time. Only people like Nadia can remember everything. Number 3, you have to see the fruits of your labor. You have to follow these people up. You cannot just put them. This is not starting a statin, firing and forget. That's not how this works. You need to know what happens. And then finally, putting it all together into a tool that helps you remember. Things like order sets and even better pathways, and there is a difference between the two, can actually make a difference, and there's data to support them. So this all starts from heart failure. We're about 10 years behind the acute myocardial infarction group. The acute myocardial infarction group led way back when I was just a baby by Kim Eagle. And they've shown several of these things that we are re-demonstrating now in heart failure. And one of them is if you start a drug in hospital, they are far more likely to be on it 6 months later, 12 months later, 2 years later. So starting in hospital is a big difference. Second, is it safe to start drugs together? I could show you a whole variety of sub-studies from clinical trials showing that some of the newer drugs like SGLTs and ARNIs actually help you manage some of the other side effects that occur with MRA, such as hyperkalemia. They actually have a lower rate, and so on and so forth. But one common question I get is, can you start an SGLT and an ARNI together in a heart failure patient? And most people are very afraid of the renal function. This is data taken from a single, very, very busy Spanish center. And if you look at these are people who had ARNI started first and then SGLT, and you can see the trend of their GFR over time, followed for about a year. Group B, the other way around. They had their SGLT started first and then the ARNI. And you can see that there's always a little bump. Interesting, look what happens in C. C is the group where they were started together at the same time. And while this was not a randomized trial, and it doesn't prove that this is the best way to do it, I think we can all agree that there's absolutely no safety signal of concern here. So it's not something that we should keep ourselves at night worried about. Now I'm going to direct your attention to the right side of the slide. This is a slide we made in Alberta to promote a score, a medical intensity score, which has actually been shown in both clinical trials and in interventional trials and in real world evidence to be associated with mortality benefit in heart failure. In other words, the better your heart failure score, see on the right how it's calculated, eligible patients for each drug, you get a certain number of points for whether you're on it at all or whether you're on it at greater than 50% of the target dose. It's easily calculated. We use an electronic database in Alberta, the whole province now. It's based on Epic. We decided to call it Connect Care. I see people laughing. I know I share some of your, I'm sure I share some of your comments, but you can do this and you can implement this score and it can be validated because we have it working now and we have it validated in Alberta. It's actually been validated in other settings. Yale was the first group to do it in New Haven. And so we are now using this as a medication score. We'll probably be using that instead of each of the others. And you say, well, how did you get this? And it's because we've actually been able to figure out a way to use a variety of AI and ancillary to get an ejection fraction in our patients as well. So we're very, very proud and happy about that. There's other ways too. I'm not going to spend a whole lot of time, but we use this technique in our early discharge clinic in Calgary when people are seen within 7 days. And it is a tool that we use to rapidly initiate and titrate therapies. And we divide it into 3 groups, as you can see here. And we always choose one drug from each group to consider at each visit. And we do that over and over again. We follow the patients every 1 to 2 weeks. And that means that within 30 days, we have everybody on all of the drugs that they can be on, maybe not at the full dose, but very close to the full dose. And our intensity score, our MFC score is what we call it, is actually very high, over 0.7, over 0.75 actually, and that's it's pretty difficult to get a higher number than that. And how do we decide what to do? Well, we've looked at some of our older data, and here's what we found. If you've got all of those things on the top banner, GFR is over 30, potassium's under 5, systolic blood pressure is over 110, resting heart rate is over 70. They are not volume depleted. This is key. Not volume depleted. And if they look like they're not frail. If you can do that, you can almost always get away with making 3 changes. That's not what we do in every case because many of our patients don't have all of these. And if they have 1 missing, then it's 2. If they have 2 or 3 of these features missing, then sometimes you can only do 1. Or straight up, if they're a frail patient, we make 1 change. Frail patients do not tolerate large changes in medications. Sometimes the large print is the drug that we like to use first. The small print is the drug that we use alternatively. And there usually has to be a reason for that. And you know those reasons as well as I do. They're just listed here. There's actually many different tools that you can use. Everything from phone-based apps that help you titrate, that help you see patients, straight up telemedicine programs. Probably the strongest evidence is for multidisciplinary teams and case management. Very, very strong evidence. Some of these that I have listed here there's some conflicting evidence. Interestingly enough, the evidence for pharmacy-based care is actually a little conflicting, depends on who you want to listen to. I personally think that it helps. You just have to have a well-functioning and integrated method. So in our clinics, what we've done is we've looked very carefully, presented on our first 113 patients. We've actually got about 560 people in our database right now. The data's not clean. And using that algorithm that I showed you, about 93% of our changes we do not have to undo. That's how we define a successful change. We didn't have to walk it back. Not bad. 19 out of 20 times that we make a change, we get away with it. I'll take that data. We average a little bit under 2 changes per visit. So it's not, we don't do 3 at every visit. It's most visits we do 2, some we even do 1. And if the data was clean, I would show you a much nicer slide, but that's all I'm going to show you because I'm not convinced that the data is clean yet. Outcomes are pretty good. But there's a few other interventions that I'm going to show you that others have published as well. A lot of them are electronic based. Most of these are electronic based. So you're going to see that more and more. And it's going to be integrated into care paths, however you have them arranged at your hospital. And it'll be how you interact with the general medical community that will determine how your particular care path is going to look. Okay, we've learned that one. It's got advantages, it's also got disadvantages, but it is the world we live in. So this is something called the PROMPT study. This was a study that was based on outpatients using Epic, the Epic platform, so electronic database. And they used they used an alert that went every time the clinician saw a patient. If the patient was eligible for a GDMT therapy for a low ejection fraction, popped up on their screen, hey, how about an MRA? How about increasing the beta blocker? Something. It didn't show up if that condition wasn't present. Or they used a cluster randomization at the level of the clinician to avoid contamination. And there's a group that did not have the alert. And at the end of their follow-up, they found that the intensity score was higher, evidence-based therapy was given at a larger. It wasn't powered for clinical outcomes, but it changed about the number needed to treat was about 7. For every 7 patients, you would get 1 medication change. That's about the average. Mostly it was MRA and ARNI, the newer drugs, the drugs that are used less frequently than the others. Not much change with the ACE and not much change with the beta blocker is what they found. Here's a little bit more complicated. This was Doug Lee's group from in and around Toronto. So they used 13 different centers in a stepped wedge. The randomization unit was the hospital in that case. It was a step wedge cluster randomized. And what they did is they used electronically calculated risk score in order to calculate a 7-day and a 30-day risk for the patients who presented to emerge, didn't matter what their ejection fraction was. And they used the score to find people who were at a low risk, as you can see in the bottom left. Only a minority of them were at the low risk. And those people had the option of, as you can see on the right of the slide, of being sent to an early clinic within 3 days, or they could go to an inpatient and then be rapidly discharged. It was a suggestion. It was not a protocol requirement. So clinicians could go and they could just admit them to the CCU or wherever they wanted to, if they wanted to. All of those who were in an intermediate and red were recommended to be admitted to hospital. Only the greens were recommended to go home. And so what they found was, sure enough, there were fewer inappropriate discharges. There were more appropriate admissions. And so there was a general improvement in the signal of safety. As you can see here, it wasn't perfect. Why? Well, because the clinicians probably didn't really believe the risk score or didn't want to follow it, or there were extenuating circumstances, or the patient refused to stay. There's a million reasons why patients don't always do what you want them to do. It's frustrating, but they have their lives to live. And you can see here, that in general, they were pretty good at hitting their targets. Being a day off, not so bad. Seeing somebody within 3 business days is extraordinarily difficult on a system basis. And at the end of the day, they actually had a lower primary endpoint, which, as you can see here, a composite of any cause hospitalization for cardiovascular death or hospitalization for cardiovascular causes. A significant, it doesn't look like much, but if you multiply that by several hundred people per year at your hospital, or several thousand people a year in Alberta, there are 8,000, about 8,000 hospitalizations for heart. That actually adds up to a large cost. So it was highly successful. They've got a lot of sub-papers coming out of it. I don't have time to go over them there. But if you have, and the key here is that there was an intervention. It was easy to apply. All they had to do was go onto a website, and it had a clear recommendation based on the outcome. So that's so important. Just telling people stuff isn't, as you will see in a minute, isn't always what needs to be done. This is something called the Better Care Design. This was also for outpatients. There were 3 different groups. One was usual care. One was a general suggestion that was given every couple of weeks to the clinician. And the third intervention was every time a particular patient came up, it said, please do this. Very specific, not unlike the prompt trial, for example. On the left, you have the alert. It had red and has orange on it. And on the right, it's just a general sort of nice, why don't we just treat them better a little bit. And what you can see is the very specific directed intervention shows a difference in intensity of medication score, whether it's early or late. It was a 6-month follow-up. The primary endpoint was in 3 months. And there was maybe a little bit of a signal for the general suggestion, but not very strong. So really, it's important to be specific. And then the most specific at all, teams that are asked to go and give specific advice for a specific patient. These are roving teams that they see an inpatient with heart failure, and they say, please start this, please start that. And you can see again over here, two different systems, one in Duke and one in Boston, and they show the same thing: an improvement in intensity of care. None of them were large enough or powered for clinical endpoints. And then finally, the trial that everyone's talking about, called the STRONG-HF trial. This is a European trial, and they looked for patients who were admitted to emergency departments who were not on all 3. This study was planned before SGLTs were approved for heart failure, so it was planned a few years ago. It was originally designed to enroll 1,600 patients, and they were randomized to either high intensity, in that they had to be on all 3 drugs before they went home from hospital, and they were seen weekly for 4 straight weeks until they were maximally titrated to their medications, or usual care, which is what their patients were getting. So this is European trial, 1,600. They had to stop the trial after 900 because of an absolute large, more than 7% difference in the primary endpoint, which was death or repeat hospitalization at 6 months. This is what the raw data looks like. So if you'll recognize a New England Journal or an Annals of Internal Medicine, because it always has 0 to 100 on it, right? So that's what it looks like. On the top is overall death, and then the second one is the COVID, during COVID, because the trial was partly done during COVID. So the top 2 are the ones you want to look at. And then there were several sub-analyses. And what they found was, yes, you can rapidly titrate people. You can do it safely, and it stays that way. You don't have to walk it back if you get them on. And whether or not they're young or old, which I've shown here, whether or not their ejection fraction is low or high, results looked the same. And then you say, well, hold it now. You can't tell me that we're going to start drugs on these people and they're not going to have side effects. Yep, they do. About half of them, a little over half of them, did have some sort of a safety event. Very few people had drugs actually stopped. But if you want to look at the safety events, you can see what they were there. So most of them were a surprising increase in BNP after they went home. of only 10%, which, as you know, is not a significant change in BNP. Usually it has to change by 30% before you believe it. And there are some renal dysfunction and other side effects that you can see there. And then on the bottom, if you're interested, you can see what the likelihood of an event was in somebody who suffered one of those side effects. There were more medication side effects in the high intensity arm, but that did not translate into serious morbidity with hospitalizations or prolongation of hospitalizations or acute kidney injury or indeed in death. So that did not happen. And you can see that the percentage of the GMT, you can see it just gradually goes down by a small amount over several months, only about a 5% change. Certainly, we're not walking back the large change. You're walking back only about 10% of what you initially gained from being in the high intensity arm. So well tolerated. So all of these have one thing in common, and that is they were specific, targeted, and easily repeatable and understandable. So that's the key for these interventions. And if you combine all of those things that work, you can make them into an order set and a care path. And this is for reference only, but you can see that there are numerous advantages. And in fact, CADTH reviewed order sets for heart failure and other chronic diseases like COPD. And interestingly, they liked it. CADTH usually doesn't like anything, right? But they liked order sets and strongly endorsed them for use in chronic diseases. Errors are dramatically, in fact, one of the biggest things that a clinical pathway does is reduce errors of medications. Huge decrease. That's probably the single biggest change that they engender. It's not actually outcomes, although they do improve outcomes. And interestingly, in heart failure, order sets and pathways in heart failure have a tendency to reduce length of stay and death and medical errors. They tend not to reduce rehospitalization rate very much, interestingly enough. In COPD, they do tend to reduce both. I'm going to skip that slide. Now, when we did our heart failure pathway in Alberta, we actually did it along with COPD. So it's, I talk about heart failure because I'm on the heart failure side of it, but we've been doing COPD for just as long as we've been doing heart failure, ever since 2010. We've been doing this a long time. And you can see that a lot of the key interventions, like any other chronic disease, and this, I haven't even mentioned, the details of admission and discharge planning, such as letting the family doctor know that patient's in, letting them know when they're being discharged, arranging family doctor appointments, and I just sort of lumped it in with discharge planning here. So there's a lot of little things that that actually are hard to implement, harder than you think. You say, sure, it can't be too difficult to implement a system to let the family doctors know patients are in. Well, do it and find out how easy it is. It's a lot harder than you think. In fact, it's almost as hard as an intervention to get them to use more beta blockers, get doctors to use. It's almost as hard as that, believe it or not. All you have to remember is some patients have family doctors, some patients change family doctors, and some patients don't have family doctors to realize what a big deal that intervention is. So when we have care paths, there's a little bit of a difference from an order set. An order set is a bunch of things that you write down that tells people what to do, but a care path is different. It includes orders, but it says when the order is made, who does it, under what circumstances they do it, and when they shouldn't do it, who they hand off to. And it also offers decision support when needed, and it also ensures that other things are in place when you write the order. So a care pathway is much more difficult to put together, much more comprehensive, but if it works well, it can actually save time and actually make a big difference to the clinician, not just to the patient. So on the left, this is a 30,000-foot view of what a care pathway is. The patient starts on the left, depending on how sick they are, they may go up to ICU, they may not, and you have different arrows that indicate a change in status. And that all happens in the background in the electronic medical record without anyone knowing. If a clinician doesn't like where their patient is, they always have the option to take them and move them. So you can cheat at checkers when you're using these pathways. The heart failure pathway is a little simpler. You can see that on the right. And I'm not going to go through all of the little details. I'm just showing you a couple of little things here. For example, this is one of our more popular screenshots. This is a COPD screenshot. and it's color-coded. Yellows are things to worry about, to look at, that you might have to do something about, okay? Pink or green, pink is a suggestion. Red is something is of great concern, red flag. Green is you're good, you've already done it, you don't have to worry about it. White and blue, so white is advice, blue is usually a link to decision support, like a guideline or a table or an algorithm that you wanted to see. So every color has a reason, and you can link into them. And most importantly, when you link into them, it just opens it up as a new window. It doesn't completely move you off that page. That's absolute death to an electronic pathway, is when you have to move off of a page. You want something to open up and not interfere with what you're doing. Here's some color codes. So green and white, you're good. Red and yellow. Yellow means you need to look at it. Red means you need to do something usually. This is what it looks like for COPD. And this is what it would look like for heart failure. On the right, you can see, okay, you're on, we're recommending an ACE or an ARNI. We're recommending a beta blocker, spironolactone, and you can see if they want to learn more about it, they can click on the blue link. So it's color coded to make it a little bit easier to understand. And you can see this is what it opens up to without having to change the page, which is a big, big difference. This is the most popular screen view on a normal sized screen like the one I have here. You can actually see everything. The writing is not too small unless you have old eyes like me and have to wear. I have it so badly I have to wear my glasses around my neck. But otherwise, you can see it quite easily on your computer screen, and it's divided into common. Now, notice we're using things like screening, mobility, consults. You recognize some of these are really general medical condition names, and we've had to put this in a format that could be scalable to other chronic diseases: cirrhosis, frailty, falls, dementia, COPD, pneumonia, etc. So this is where we intersect with the real world, and we try to enable our pathway to be used so that it can still be scalable without interfering with other pathways. One of the biggest pushbacks you're going to get is people will say, well, we need a chronic disease management order set or pathway. We want to be disease agnostic. But the problem is, if you do that, then what'll happen is you will only get the heavily bolded areas of your pathway, and all the rest of it will be lost. And of course, most of the benefits that I was talking about for heart failure resided in the non-bolded areas. So I do not believe in disease agnostic order sets, or I believe that you need to tailor them, and you need to understand that a medical disease that someone has needs to be treated. It can't be lumped in with all of the others, and then they're all treated generically. This is data from the first 15,000 patients that we had in Calgary. This was before the pathway was made. This is our order sets. Back then, we were using Sunrise Clinical Management, and you can see that we had a lower length of stay. This is propensity matched for like 60 different variables. Interestingly, not a lot of differences between the patient profiles who were on the order set versus those who weren't. Not a lot of, you'd be surprised. The heart rate was identical, for example. And you can see that we see mortality signals and length of stay signals, not necessarily hospital alone signal. This is actually in keeping with the literature. And then when we moved it over to the pathways, while we were rolling out the pathway, we were using some centers were still using paper, others were using electronics. This is our hybrid model. And what we saw was when you were using the full pathway, you're getting absolute 4% differences in readmission rates and a much higher rate of proper referrals within target times for outpatients. So a very big, and this translates into quite a significant number. So actually cost saving is what the calculations were. And then for the first 5,000 patients that we've had for our pathway, we included pathway plus order set. And as you can see here, using, this is just simple multiple logistic regression. This is not a propensity analysis. And it was a lot fewer variables because getting variables and validating them out of Epic based platforms is quite difficult to do, and it's slow, and we haven't got that model done properly yet. But you can see that based on an old-fashioned linear multiple regression, you can see that that there's a 25% signal for benefit in this very, very non-randomized real-world data set. So sounds good. What can go wrong? Well, there's 1,000 things that can go wrong, because you're beginning to realize that thinking up the intervention is actually only a tiny part of what you need to do. And you need to set it up so that other people will use it. And it becomes really a social implementation. A lot of these things aren't really about science, pure, hard medical science anymore. They're more social, because you're trying to get your peers to change what they do. Well, first and foremost, with a lot of activity, with a lot of work, people on the ground, local councils, we see an uptake of about 50%. Two things are very important that we've seen. Number one, local buy-in must occur. It has to occur at the local user level. It has to occur at the local leadership level. Without that, you're dead. And the second part is you need to keep at them, and you need to keep at them. Did I say you need to keep at them? Because you do. Because they will forget about it. It's not necessarily core. And you can see there's a huge variability in the level of uptake according to whatever hospital. It ranges from 10% to 100%. You know, some of these hospitals have very low volumes. Some of these hospitals have very high volumes. And imagine how difficult it is to implement a heart failure pathway to a hospital that only has 30 hospitalizations for heart failure every year. That's one every other week. Not easy. But it adds up. And I know you have a lot of smaller hospitals in Quebec too. This is not unique to Alberta. Then the hard part. The harder part. This is what happens when you're looking in the context of what else is happening in your medical system. So in Alberta, there's 120 hospitals. And there's a lot of different chronic disease management groups, and they all want their own pathway. They all want their own. So these are all the initiatives on the top. You don't have to read them. You can just count them. There's elder care, fall prevention, frailty. There's bed sore, which is part of elder care. There's discharge planning. There's a couple of surgical initiatives. Let's see, what else we got here? We got a couple of, we have family orientation, rapid rounds, and transitions, and so on and so forth. These are all the initiatives. Only one of these is a heart failure pathway, and only one of these is a COPD pathway. And so all of this is happening at the same time. It's confusing to the leadership, who have to choose and pick what they're going to do. So what you want is make your intervention as scalable and as unobtrusive to what else other people are doing as you can. And that's why some of our items were called something slightly different that I pointed out earlier. The other thing is, why is it important to keep at it? People talk about sustainability, and one of the biggest mistakes is that they'll have an intervention, they'll show a benefit, they'll slap each other on the back, and then they'll go do something else. What happens when you do that? Well, see the little red? It's a bit small. You see there's a dark number and then a red number? Well, this is over time. This is when they looked at the last quarter, and the black number is, yes, we met our target. The red number is, oops, we slipped back. We didn't do it. And you can see there's lots of them. There's others that I haven't circled, but you see that. And so it's so important when you do these that you have a measurement system, that it's automatic, and that you keep measuring 1 or 2 or 3 key metrics over time to make sure. One of the things I have found to be very useful is measurements of daily weights for heart failure. Because if they're measuring daily weights for heart failure, there's a high likelihood that they're doing other things for heart failure. That's what we found. They tend to cluster together. There's a couple of others too. For example, measurement of LV function is another good one that's associated with other activities. And then the MFC score is the other one that we're following. And there are situations where large implementations don't work. For example, in the PACT trial. The PACT trial, they wanted patients to be seen quickly after hospital. They provided teaching to the, this was a cluster randomized trial. Harriet Van Spal is a super talented researcher. When she does something, she does it right. What they learned is if you don't tell them exactly what they're going to do when they see these people, then you may not get the benefit. Because what happens is they're seen 3 days later. There's no super plan to get them on aggressive medical therapy like they were in the STRONG trial, and nothing happens. There was a slight increase in quality of life scores and a slight increase in patient awareness of their disease and their disease knowledge score because they did get the teaching. But in terms of harder outcomes, they didn't see much of anything. And then the REVEAL trial, this is just telling people what the risk of your patient is. This was just an original. This is the very first one that was published out of the EPIC group in New Haven. And it turns out that simply telling you that your patient's sick and not going to do well, so what? I've got a lot of sick people. I've known that for years. I need something to help me. So no specific solution or action was recommended. It didn't work. And then prompt to AHF. That's that trial I showed you earlier that worked in the outpatient setting. Well, they tried the same thing on the inpatient setting. There was a signal for slight improvement, but it did not reach statistical significance. It was a smaller trial with only 500 in each arm. But what it tells you is it's probably more difficult to make that work as an inpatient because there's a lot more going on. And so just because it works in one setting doesn't always mean it works in another setting. So that's mainly what I wanted to show you. I just have a couple. I don't know how I'm doing for time, Nadia. I have about 5 more slides. Oh, yeah, easily. So if you're thinking of doing an implementation, there's 1 or 2 slides I want you to look at. This is one of them. This is what people are like. So you have your group, your Einsteins, your Marie Curies on the left. They're the innovators. 9 out of 10 of their ideas are crazy, but one of them is ground changing. It changes the world. They're the ones that come up with the bright ideas that we do this. The early adopters are the ones that run with a lot of this or are influenced by it. And they're the ones they're the eggheads, they're the academics, they're the leaders, they're the entrepreneurs, the innovators. They're the ones that take those ideas and start to make them work. All right? They're like Jim Balsillie, okay, for lack of a better word. And so the guy that made the microchip is the innovator. Balsillie is the early adopter. And early adopters cannot do this by themselves. They are voices crying in the wilderness. These are highly, highly educated people. They're highly driven. They're usually a little solitary. The key group you have to influence are the early majority. These were the cool kids in high school. These were the kids who went to the parties. They had a lot of fun. They're the ones you see clapping and cheering in the stands, or playing the game or whatever it is on TV. They are the ones that move it. They move the needle, and that's the group you have to get. The early majority. The late majority, they're the guys that say, well, they're doing it, I guess I'll do it. And then, of course, the laggards, these are, quite frankly, they're the vaccine deniers, right? And they're a different animal altogether, but fortunately, they're not a very big group. So the mental model, localists, opinion leaders, self-propelled, early majority, highly socialized, and they need to be involved. If they are not involved, so if you have an idea and you want to start something, you need these people there at the first meeting. You can't make your idea, you can't develop it, and then bring it to them and say, do this. You cannot do that. It will not work. They need to be there. So important. Because what'll happen is you'll start up a small project yourself. It'll maybe be successful. It maybe won't be. And then when it's time to scale it up, you hit what's called the valley of death. Nothing happens because they weren't there. That is maybe the number one mistake people make right there. I'm going to skip this slide except to show you that there are several different implementation frameworks. They all base to a larger or a greater or lesser extent onto this. It's about people. It's all cycle driven. It's all about identifying problems, looking up the literature, coming up with a solution, implementing the solution, and then measuring the effects. It's basically an engineering, or what we would call a PDSA loop is what the engineer would call it. And so you need to have And why do you need, in a healthcare system, this is specific to healthcare right here, to get a large scale change, you cannot do it with doctors alone, and you cannot do it with administration alone. In fact, that's why many healthcare institutions have what they call hybrid or dyads. They have a physician with an administrator together. Has its problems too, but that's the current thinking. Must have the stakeholders identified and involved. They need to own it. There needs to be excellent communication, and your measurement strategy needs to be there before. If you start measuring halfway through, big problems. And there has to be accountability, or otherwise it will not get done. That's just a slide in case you wanted to look at it later with all of the type. I'm going to say lastly, this is there's three essential models for how you measure this. You can use cluster randomization, adaptive randomization. I'm not going to talk about clinical trials. I'm not an expert in clinical trial design, so I'm not going to waste your time. But I will say that when it comes to healthcare implementations, you have to think a little bit about what kind of implementation you want and what kind of evidence it has. And if it has pretty good evidence, but not great evidence in a variety of different settings, then you're going to want to really look and make sure that it's safe and that it's effective, and then look at the fidelity and the uptake and the feasibility as a secondary. If you have a really, really, really well-proven therapy that you know works in multiple different settings, then you want to focus more on the uptake and the feasibility and the fidelity of the intervention, and you can look at outcomes secondarily because you kind of know what's going to happen if it's taken up there. And then, of course, hybrid 2 is the typical Canadian compromise. So it all looks like a PDSA loop. It always goes out. For some reason, it always goes clockwise, never counterclockwise. You can mix and match, but at the end of the day, the idea here is to show that you're looking at a problem, you're looking at the evidence, you are constantly adapting what you're doing, and it's not like a basic science project where you can't make any changes until you get your final answer. It is quite acceptable in this business to make changes as you go, as long as you can justify them and that you document them well. So, hope I didn't take too long. Wanted to talk to you a little bit about medical therapy and heart failure, how we get it to patients, a few ideas, some things to do and some things not to do, and hope the rest of your day is a good one. Thanks.
Fantastic, John. Always a pleasure listening to you speak. Fantastic. Thank you for this, not just for the presentation, obviously, but for advancing the heart failure care, heart failure delivery of care and care pathways. Really amazing, fantastic work. I'm glad you guys were able to do this in Alberta. There's a couple of questions here. Louise Pilote, great review of intervention on anything that is sex-specific, mostly social determinants of health, many of which are sex-specific. Any comments on that?
I'm not sure exactly what. So, in terms of implementation science, there's a lot of there are some nuances in interventions that work better with women than with men. Engagement is a very different animal with women versus men, of course. So from that side of it, I haven't seen this much. I do know we got a couple of, we have Rupi Santu and a couple others in Calgary that are just starting our women in cardiovascular disease clinic. And the engagement strategies are quite different for the patient populations. And the engagement strategies, I think Louise could probably tell me a lot about more than I can tell her about that. But I would say that the engagement strategies are key. They're very, very different, and we still haven't figured it out. Those would be my three most important comments, I think.
Thank you, John. David Rosenblatt is asking about, because this seems like a well-coordinated effort. Is there an umbrella entity in Alberta or healthcare units that try to coordinate these terms of giving care to populations rather than subpopulations with specific diseases?
Yeah, I would characterize it as a struggle. And you've hit the nail on the head. There's a tension in our province between, there are those in general care who really want to push the generic general medical care, things that happen to everyone, and they want to de-emphasize the disease-specific nature of what's happening. And I think I've already made it pretty clear to you where I stand on that. The trick, though, is to not let that take over, and that's what I think the generalists are more afraid of than anything else. I think they're okay with you having as an option your disease-specific interventions, but they just want to make sure that the determinants of health, that the hugely scalable social aspects of disease prevention are not forgotten, and that they're not dominated by, here comes Howlett with his cath labs and his implantable monitoring devices that take all our money. I think that's really where a lot of and of course the people will always advocate when they're involved. They're going to advocate the areas where they're expert in. And if you have a generalist who doesn't do specialist cardiovascular medicine, then they are going to emphasize the parts that they're good at, because that's what they have to offer. So I characterize it more as attention than anything else. Part of your question is above my pay grade. So there's a couple things. Alberta has spent, I think it's like 2 billion in the in information technology piece for this. It encompasses about 4.3 million people, I think, right now is what its latest at. So scalable, it's going to be a lot smaller than Quebec. There's something called an apple orchard, or the orchard. I call it the apple orchard. I think it's just the orchard. And this is they have a system set up where vendors can put forth their software, and it can be approved that it can connect to what we call Connect Care. You call it Epic. Everyone else in the world calls it Epic. We call it Connect Care. And so that has gone very slowly. But there are vendors. There's one local company in Calgary, for example, that has now has permission to work within the AHS firewall, and I'm personally work with them. They're called Cohesic, and they're doing our patient-facing heart failure apps, and they're doing a good job with that. So that's one thing that they're doing. The second thing that they're doing is they are streamlining the ability for private practitioners to upload their notes, their test results into the backbone. And the third thing that they're doing is there's a whole department where, for example, a family doctor in Medicine Hat is actually the person who authored. So I'm the official author of our heart failure pathway. So if you look at it online, it'll probably say Howlett, but Vince Danino is actually the guy who wrote it. He's a super user, but also is able to go in behind into the back end of Connect Care and actually make the things that I was showing you and change them when they were not working well. One thing I glossed over in our presentation today is that we spent more time responding to feedback and problems than we did actually writing the pathway, and so that iterative process is so important. So I would say, on balance, within their means, they have been pretty good about promoting pathways. That's what they want to do. Cirrhosis, COPD, heart failure are the first three. Heart failure was the first, and COPD second, and cirrhosis just finishing now. And they're planning for a few others as well. And then they're being gathered together in something called the bundle. Remember that series of 16 different interventions I showed you towards the end with the writing that was too small? That was part of what we call our care bundle. And that's how it's being collated. And that's actually being run through the medicine strategic clinical network. So it's being brought into that larger generalist group. Not a full answer, but part answer.
So it's coming up on, actually, it's past 1 o'clock. So there's a few comments there in the chat about teaching implementation science in medical school residency to equip young graduates to not only integrate knowledge, but to translate it. Agreed, need to understand how to bring about this change. So I think, obviously, you've brought a very interesting point to the table. I think we have a lot of work to do here. To catch up. One of the issues is, what Mark is alluding to, we don't have a cohesive EMR that everybody can, is part of. So our care tends to be disjointed between the the specialist, the family doctor, the internist, the internist, and whoever's taking care of the patient. So it's a little bit complicated in Quebec right now, but we're very optimistic when we get EPIC. But obviously, that's not going to be enough. There needs to be a lot of work done. Thank you very much, Jonathan. I wish you a great CCS meeting. Thank you for stopping on your way into Montreal, for joining us for this fantastic lecture, and congratulations on all the work you've done. I wish everyone a great afternoon. Thanks for participating in today's medical grand rounds. Bye-bye.
Thanks, guys. Thank you.